Hi, I'm Carrie, and I'm an occupational therapy student today. And today we're going to demonstrate a hand examination and a forearm examination. This is my patient Bree, and the first thing that we want to do anytime we're doing a hand examination is we want to have a thorough patient history. So we want to find out if the condition is acute or chronic. And if it's a traumatic situation, you'll want to know the date of the injury, how the injury occurred, and what position the hand was in when the injury happened. If it's non-traumatic, you will want to know if it's an acute or chronic condition, what the date of onset was, if there's any symptoms that are getting worse over time, whether there are situations that make the problems better or worse, and also what functional effects will be related to the injury. For any situation, you'll want to know any treatments the patient has had up until now. We'll look at the nervous system. We'll want to know whether there's any pain, shooting, deep, dull pain, and tingling in the forearm and hand. We'll also look at the vascular system, checking for any color changes and making comparisons to each arm if there is any stiffness or swelling, checking capillary refill by adding pressure to the pad of the finger or the fingernail just enough to blanch the surface. And when you release the pressure, there should be a return of a pink color on the surface in about 2 seconds. And we want to compare that with the other fingers in the hand. So I'm going to demonstrate the capillary refill. So I'm just going to apply a little bit of pressure to her fingertip and then release, and it's pink right away, less than 2 seconds. So she has very good capillary refill. And we'll also want to look at the range of motion by making sure the patient can touch their thumb to their shoulder on the ipsilateral arm. So Bree, can you touch your thumb to your shoulder? Okay, good. And also with the elbows tucked in, they should be able to pronate and supinate the wrist. Okay, very good. With the elbows on the table, the patient should also be able to flex and extend the wrist down. So like this. Okay, good. And also another way to, and we'll do this to check for symmetry as well. We'll also have her bring up her arms like this and then flat on the table, and we're just checking the alignment and the symmetry of both extremities, making sure they look pretty much like the same and normal. Okay, and then another way to do that is actually having the patient with the back of their hands touching like that. And so again, we're just checking for symmetry there. Next, with the elbows on the table, we're going to have the patient also flex and extend the fingers. So just going to have them open up their fingers and then close them, and open and close. And we're also going to make sure that they can touch their thumb to their base of the pinky metacarpal. Just like that. Okay, so now we're going to go over the wrist and finger flexor muscles and extensor muscles. So on this side of the arm, you have the extensor muscles. We have the superficial and the deep. And so we'll start from the superficial. We have the brachioradialis muscle, pronator teres muscle, extensor radialis longus muscle, extensor radialis brevis muscle, extensor digitorum, extensor digiti minimi, and extensor carpi ulnaris. Then on the deep side, the deep layer, you have the supinator muscle, the abductor pollicis longus muscle, abductor pollicis brevis muscle. Then you also have the extensor pollicis longus muscle. And those are the extensor muscles. Now we'll flip over to the anterior part of the forearm. So again, superficial, we have the pronator teres muscle. We have the flexor carpi radialis muscle, the flexor digitorum superficialis, and the flexor carpi ulnaris muscle. So going back to the deep layers, we have the flexor digitorum profundus muscle and the flexor pollicis longus muscle, with also the pronator quadratus muscle at the wrist. Okay, so when checking for tendinitis of the elbow, wrist, and hand, you will want to isolate the tendons that are problematic. For a very common situation like lateral epicondylitis, which is also known as tennis elbow, there will be pain in the lateral epicondyle when performing a manual muscle test on the extensor muscles. For medial epicondys, which is also known as golfer's elbow, there will be pain in the medial epicondyle when performing manual muscle tests on the flexor and pronator teres muscles. In the wrist, there are 6 compartments of the extensor retinaculum: the abductor pollicis longus, the extensor pollicis brevis are in the first compartment, and the wrist extensors, extensor carpi radialis brevis and longus, are in the second compartment, and extensor pollicis longus is in the third compartment. Extensor digitorum and extensor indicis are in the fourth compartment. Extensor digiti minimi is in the fifth compartment, and extensor carpi ulnaris is in the sixth. Any of these tendons can become inflamed. The most common is inflammation in the first compartment, which is also known as Decker-Vane syndrome. A positive response for the Finkelstein's test will also diagnose this syndrome. To perform the Finkelstein's test, you will have the patient flex the thumb and ulnar deviate the wrist while you palpate. If there is pain, the test is positive. Occupations that are commonly associated with this diagnosis would be golfing, racketing, mail sorting, and filing clerks. There is also an intersection syndrome, which is a diagnosis of inflammation and pain in the intersection between the first and second compartments, which is about 6 centimeters proximal to the radial styloid. To test, you would have the patient extend and radial deviate the wrist, and you will palpate at the intersection while manual muscle testing, and a painful response would be a positive intersection syndrome. Repetitive wrist motions are associated with this diagnosis. Weightlifters, rowers, canoers may have this problem. Patients with radial-sided tendinitis can also have triggering when they flex the thumb or the fingers. Patients with digital triggering often have pain or a nodule along the flexor tendons at the level of the A1 pulley, just proximal to the metacarpal phalangeal joint. You will palpate at the A1 level and flex the digits. A positive response would be painful, and you should be able to feel popping or catching in that area. When examining the wrist for flexor carpi ulnaris and flexor carpi radialis tendinitis, resistive wrist flexion and radial and ulnar deviation while palpating the tendon will also elicit a painful response. The flexor carpi radialis longus tendon runs radial to the palmaris longus tendon. No, this one. Palpation and resistance to that area would elicit pain. Flexor carpi ulnaris would be tested by ulnar deviating the wrist and applying resistance. Patients can also have pisoquetral arthritis. The flexor carpi ulnaris tendon runs on the pisiform bone. and the patient may have pain with resisted ulnar deviation and flexion while palpating on the pisiform bone. So grinding the pisiform bone into the triquetral bone would elicit pain. Less common tendinopathies might include tendinitis of the extensor pollicis longus tendon, which is in the third compartment and runs around the Lister's tubercle. Extensor pollicis longus tendon, which is in the third compartment and runs around the Lister's tubercle on the radius. Resisted thumb extension while palpating on the Lister's tubercle would be painful. You can also check for tendinitis of the finger extensors by having the patient extend their fingers and palpating the area of the fourth compartment, where the extensor digitorum runs through would be painful. There can be tendinitis with extensor carpi ulnaris tendon, where it can slip over the ulnar head, causing pain and unstabilization. To check for this, you would want to supinate the forearm and extend the wrist and ulnar deviate the wrist with resistance while palpating along the extensor carpi ulnaris. Okay, relax. This may elicit some pain. You may even feel the tendon slipping over the ulnar head. The carpal bones in the wrist may have instability and ligamentous problems at the lunate triquetral joint, lunate scaphoid joint, and the lunate scaphoid joint. From Lister's tubercle on the radius, a centimeter distal and laterally would be the scaphoid bone, the lunate, and the triquetral bone. Beneath that is the pisiform bone. Putting your finger on putting one thumb on the pisiform bone and the other on the triquetral bone, you can actually rub these bones together, and this would elicit pain. Scaphoid fractures are the most common fractures, and so can you put your thumb up like this? The scaphoid bone is at the bottom of the anatomical snuff box, and this would be a place to palpate to see if there is instability or pain that might indicate a scaphoid fracture. Along the anterior portion of the forearm, we have the carpal tunnel that is covered by the flexor retinaculum. The finger flexors and long flexors of the thumb make a total of 9 tendons running through this carpal tunnel. The median nerve also runs through the carpal tunnel, and there can be problems with the median nerve in this region right here. The Tinel's test and the compression test with flexion of the wrist can elicit pain or tingling of the fingertips and the medial nerve distribution. These tests can also be used to test ulnar compression in the Guyon's canal. For wrist instability, a Watson scaphoid shift test would be used for scaphoid instability. You can use your thumb to push in dorsally on the scaphoid tubercle and deviate the wrist, and this will release a little pressure on the scaphoid tubercle. You might feel a pop or jolting when doing so that may indicate a scaphoid lunate abnormality. What also may indicate a midcarpal or lunotriquetral instability would be a Littman test or a Catch-Clump test. Deviating the wrist back and forth, you may feel a clump. Cubital tunnel syndrome may also be an issue with the ulnar nerve. It comes around the medial epicondyle in the area of the cubital tunnel and continues down the forearm. Pain may be elicited with flexion of the elbow or with the Tinel's test in this area. Patients will complain of numbness on the dorsal aspect of the area innervated by the ulnar nerve. All right. If compression of the ulnar nerve is not at the elbow but at the wrist area, there is already a branching of the ulnar nerve, so sensation of this aspect will be intact. There may be sensation issues on the volar aspect of the hand. However, patients with carpal tunnel syndrome may also have involvement of the thenar muscles and some intrinsic muscle problems, and may not be able to cross their fingers or thumb adduction. A positive Frohman sign is indicated when the thumb IP joint flexes to hold an object in place when you try to pull it away, secondary to intrinsic muscle weakness. So the DIP joint, or the IP joint of the thumb, flexes to hold the object. Okay? A positive Wardenberg sign is done by observing and examining the little finger and seeing if it is unable to abduct to the ring finger. Carpal tunnel may affect opposition of the thumb and little finger. The thenar muscles may have atrophy or be soft when opposition is taking place. There is also carpal metacarpal arthritis of the thumb. One can do a grind test where you are grinding the metacarpal into the trapezius, and that would cause pain. There is also gamekeeper's thumb test that examines ulnar collateral ligament involvement. You could support the metacarpal and then deviate the thumb back and forth to check the status of the ligament to see if there is any laxity. Okay, finger flexors include the flexor digitorum superficialis, which is made up of 4 muscle bellies coming through the carpal tunnel to insert on the middle phalanges and flexing the PIP joint of the finger. Deep to flexor superficialis, you have the flexor digitorum profundus, and it goes all the way down to the distal phalanx of each finger, 2 through 5. And it helps to flex the tips of the fingers. These can be tested by having the patient flex the finger up to check the status of the FDS and FDP tendon. So to check for the FDS tendon, I would ask her to flex there. And then to check for the profundus tendon, I would have her to flex the tip. Okay? Radial nerve palsy is a condition also called wrist drop, when the radial nerve supply to the extensor muscles are no longer functioning. To test this, you will want to isolate the flexor digitorum muscles, and you can do this by having the patient flex the fingers and extend at the MCP joint. You want to make sure that the patient can extend the wrist and that the thumb can cross over the index finger when on a flat surface. With ulnar nerve palsy, you will see a claw hand. There is hyperextension of the MP joint and flexion of the IP joint. Boutonniere deformity is a flexion or neutral MP joint and a flexion of the PIP joint, but an extension of the DIP joint. Swan neck deformity is where there is hyperextension of the PIP joint and flexion at the DIP joint. Boutonniere's deformity occurs when the central slip of the extensor digitorum is injured at the middle phalanx. The lateral bands lose their connection to the central band, so they drift more anteriorly towards the PIP joint, causing the joint to flex. The position of the lateral band of the distal phalanx remains intact, but because of the flexed position of the PIP, the lateral bands now move more posterior to the axis of motion of the DIP joint, so that joints become hyperextended. The swan neck deformity occurs primarily with arthritis and a subsequent weakness of the intrinsic muscles, so the PIP joints can deform into hyperextension, and then again the distal DIP joint is flexed. When examining patients for suspected finger fractures, we will look at the nail plane. If the finger is twisted or out of plane, there would be a rotational deformity and indicates a proximal fracture and dislocation on that axis. If you can see all metacarpal heads in alignment when the patient makes a fist, there is no metacarpal fracture suspected. To test for sensation, the 2-point discrimination test using a paperclip spaced 5 millimeters apart can be used to see if the patient can discriminate between a 1-point and a 2-point with the eyes occluded. This can be performed statically or dynamically. Normal is less than a distance of 8 millimeters. That concludes some of the testing that can be done for a hand evaluation. Thanks, Bree.
You're welcome. Thank you.
All right.